But by December of 2020, pandemic, administration working from home, telling you, oh, we don't have PPE for you, but you still need to take care of dying COVID patients. It finally realized that, hey, this is taking a toll on me and my family and everything else. And so why am I continuing to do this? So December of 2020, I quit my employed position, and May of 2021 saw my first DPC patient, and it's been a roller coaster since then.
So today I have with me Dr. Wendy Molaska, who is a wonderful family physician, and we're going to learn so many interesting things about what she's doing with DPC today. So we met at the Greenville Mastermind in 2021.
Yes.
Yeah, 2021. And I think, had you opened
barely.
already?
Yep, a couple of months.
Okay. So I'm going to let you kind of tell us about your practice. Dr. Wendy Molaska.
Yeah, thanks
Welcome.
for inviting me, and I'm really looking forward to this because, it's basically like we just get to spend some time chatting. My practice is dedicated family care, and we are family medicine, so womb to tomb. I just signed up another patient for hospice the other day and have pregnant women and everything in between, which is awesome. And I opened in May of 2021. Finally, I first heard about DPC in like 2019, but at that time I had two young kids, and actually I was also just diagnosed with breast cancer at that point. So I was like, I can't do that. I can't start a business and deal with all this other stuff. But by December of 2020, pandemic, administration working from home, telling you, oh, we don't have PPE for you, but you still need to take care of dying COVID patients. It finally realized that, hey, this is taking a toll on me and my family and everything else. And so why am I continuing to do this? So December of 2020, I quit my employed position, and then in May of 2021 saw my first DPC patient, and it's been a roller coaster since then. But yeah, we have expanded. I started as a
roller coaster, good and bad.
Good and bad, exactly. And I think that's one of the things is like somebody said this, you hear all these sayings and stuff in DPC, and I think one of them is that the worst day in DPC is still better than the best day in employed medicine. So I think that's one of the things I take business aspects of it, but being able to practice medicine the way I was trained and feel like I'm actually helping people is huge. So I think that's kind of the biggest thing from that. But yeah, I opened as a one-room micropractice. I had a one-room suite. It was just me, exam table in one corner and desk in the other corner. And I was the receptionist and the medical assistant and the phlebotomist and the janitor and the doctor and everything in between. And once I started growing, I started attracting a Latino population, and my Spanish was kind of rusty. So one of the nurses that I'd previously worked with, she was originally from Bolivia. She was an RN, and she was a certified medical interpreter. So I started per diem, just kind of calling her in every once in a while to help with interpretation, and then eventually hired her part-time. We expanded into the clinic that we're currently in. So we now have 3 exam rooms, 1 procedure room, a small reception area, an office for the docs and stuff. And she came on full time, eventually hired a medical assistant, one that I'd also previously worked with. I keep stealing people from other organizations. It's wonderful because you already know how they work. And she was initially part-time because she was going to nursing school, but she is now an RN. She is originally from Ecuador, and she is trilingual because she speaks English, Spanish, and her indigenous language of Quichua. So she's also taking the medical interpreting course so that she can be certified as a medical interpreter, but she interprets as well. After her, we added office assistant. Super lucky to have him. He is actually this nurse's cousin, which is how we found him, but he was working at a credit union, really good customer service skills, just a real go-getter. And again, he's from Ecuador, so speaks English, Spanish, and Quichua, and agreed to come on board as kind of our office assistant. So he does a lot of our front office work, behind the scenes work, and yeah, he's just been amazing. And then as of 2 weeks ago, we added our new physician, Dr. Amy Watio, and I am so excited. She is awesome. She is also bilingual, English and Spanish. It's been a whirlwind. We are continuing to grow, and it has just been fantastic. And yeah, everybody's like, would you do anything differently? And I think the one big thing is always people are like, well, maybe I would have gone into DPC earlier. And I don't, how good this could be.
Yes, that's definitely something most people say is I wish I'd done it sooner, but you don't know what you don't know.
Exactly.
So, So I'm curious, how did you find your new physician? That seems to be a really hard thing for DPC doctors right now to find other doctors to join them.
Yes. So I actually had found a physician. It was not a good fit. I had hired someone. She started, ended up quitting within 3 months. So huge learning experience, good and bad, but you take your lessons from it and stuff. But this one, so interestingly enough, I've been doing a lot of talks and I have med students, nursing students, pharmacy students, all kind of residents rotating at the clinic. And so I did a talk at the local residency program. So in Madison, we have a family medicine residency program. We have the medical school here. We have a lot of training programs and stuff. So I was doing a talk about DPC at the residency. And Dr. Watio was at that talk and was like, oh, this sounds really cool. And she came and rotated at the clinic and got some experience seeing what this was actually like. When she graduated in June of this year, we had signed a contract back in like January or something so that she would be starting here. She took a few months off, which who can blame her after residency, and now just started the other day. So mine was actually kind of fortuitous that I'd had this experience of going into a residency, doing a talk, having her rotate out here as well and stuff. But I think you're right. I think it's been hard for people to find docs for these positions.
So she was a third year when she heard your
She was
talk,
actually a second
or
year, yeah, when she
before
heard
that?
my talk. Yep. And
Second year,
then
okay.
rotated as a third year.
I think that obviously the earlier that people know about DPC, they can start planning, but that's perfect. If she's second year, then she can plan her third year
Mhm,
with rotations. That would be really helpful coming out
mhm.
and going directly into DPC
Yeah.
since that's her first job. That's I think that would be great. It might I would think for me it would have been hard.
Uh-huh. Yeah. And that's one of the things when I look back
But
over my career, I'm really happy with the way my career has played out over the last 20 years. So, like out of residency, I was at a rural FQHC and we were in the middle of nowhere. And so it was you or no one. And so you're still on that kind of steep learning curve out of residency. And all of a sudden, oh, a 26-weeker comes in and delivers, and you got to wait an hour for a helicopter to get there. You're like, okay, I guess I'm trying to put in lines and do all this stuff that because it's me or no one. And so I think that experience was really helpful to be able to really expand my knowledge base, my confidence, my procedures, all of that kind of stuff, which now I'm able to again use in DPC and do all of these different skills and stuff that I've learned over the years. So I do colposcopy and endometrial biopsies and
mhm,
all of these other things,
mhm.
which I think is hugely important. I think in this situation, again, because I'm already experienced in the situation, I think for Dr. Watio, it's going to be good because she is like, okay, I want to learn how to do, this. And I'm like, okay, great. I can teach you how to do that. So some of that's going to be great. But I wouldn't go back and change anything that I did in my career
Yes.
to end up here.
Right. Yes. And actually, on the flip side, since she's very fresh out of training, so a lot of that stuff, like the more specialized things, like the colpo and endometrial biopsy, she's very fresh with just
Mhm.
having learned it within the past few years. So that's also good. I mean, that's another bonus for coming out of
Yeah,
residency, I
I think
guess.
the big thing too is one of my fears was always as we age as family practice docs, you get set in your ways. And I remember working with this one doc when I was in medical school, and like the stuff I was learning in medical school was way ahead of where he was. And I was like, what are you doing? Why are you doing this? This doesn't make any sense. We were taught this in medical school, and the evidence shows this or whatever. And so my fear has always been to be one of these old docs that has never kept up with all of the changes and the times. And so having this young person right out of residency, and then this is also part of the reason that I try and have, yeah, med students, residents, all these people rotating at the clinic as well to kind of keep me fresh
Mhm.
and make sure that I'm staying on top of everything as well. So, yeah,
Yes.
she brings a whole wealth of knowledge and stuff
Mhm.
that is really up to
Yeah.
date and so forth. Yeah.
Well, I'm going to back up a tiny bit. What you learned from hiring that first doctor, what do you think? Were there red flags, or was there something that you wish you had picked up on sooner?
So I think at that point I was so desperate for another doc that I kind of settled and I didn't pay attention to some of the things that I should have. So this was an internist, but she had gone on to do pulmonology and palliative care and hospice. So really she was a specialist. But when she came and interviewed and stuff, she was like, I really want to get back to nuts and bolts. I really want to go back to doing primary care and so forth. What we quickly realized when she started, because again, it's different than having a resident come out and rotate and kind of see how things go. She did come out and like shadowed for a day and stuff like that, but it's different than actually seeing somebody at work and so forth. And so what we quickly realized is she's a specialist and that just doesn't work in primary care. And so there are a lot of just basic stuff that we had to go back and be like, oh, she's like, I haven't done a PAP in 10 years. How do I do a PAP? And we're dealing with acute, chronic, and preventative care and trying to sometimes do all three at once. One situation I remember was one of her patients called into the clinic early in the morning at 9, 10 in the morning, and they're like, hey, I cut my finger. I think I need stitches. And I heard the staff talking to her, and she's like, well, I don't have any openings, and blah, blah, blah. And I'm like, wait, that's not how DPC is. If somebody calls in and tells me they need stitches, I just say, come in. That's not how this clinic is supposed to run. It's like, yeah, if you have that acute need, you just come in and we work it out. Especially because most of our visits are so long. It's like, if you have a 60-minute visit with a patient, sometimes you don't need that whole 60 minutes. So the 15 minutes that takes to put in sutures is not going to be a big deal. And then I started hearing some patient complaints as well, which was really tough. And I think I took that very personally because up until that point, I had not had like any patient complaints. We kept getting great Google reviews and patients always saying how comfortable they felt here at the clinic. And now we had people saying that they don't feel comfortable when they're talking to her and they don't feel heard. And I think that's the one thing people don't realize either about DPC is you are the brand. And so I worked really hard to build my brand, and the brand is me. And now I have somebody else here who is also going to be part of my brand. And to hear that patients are just like, I don't feel like she was listening. I don't feel heard. All of those things were really bad. Yeah, we decided to part ways after about 3 months, which I think was good for all of us.
Mm-hmm. So it was mutual then?
It was kind of a little bit of both. Yeah.
Maybe not.
It was kind of a little bit of both. I think she was surprised she was very surprised, I would say, when I sat down and tried talking to her about some of the concerns that I had. And I think then she was very uncomfortable because I think nobody wants to hear that you're getting patient complaints and that you're not meeting patient needs and stuff. As doctors, so many of us are type A and perfectionist and stuff like that. And I think that's probably really hard to hear. And so I think that was probably a blow. And so then she quickly made the decision that she just didn't want to continue. Yeah.
Well, definitely a learning
For sure, a learning experience. And I think, like you said, the big thing was that, and everybody always says this, hire slow and fire fast. And the fire fast happened, the hire slow did not. And I think that was the biggest problem there was like, I was like, oh, there's a doc, she's interested, she's available now. She doesn't have commitment where she has to give 90 days notice or any of this other stuff. She could start tomorrow, blah, blah, blah. And so there was all this stuff where I was like, and I have a wait list of all these patients and I feel bad turning patients away and stuff. So let's get her in and let's get her started and stuff. And that's where I think I made my biggest mistake was like, hey, we should do more vetting. We should actually look at this a little bit more. And yeah.
Yes. So hiring out of desperation is not a good thing.
Exactly.
Rarely does it work out.
Exactly.
Well, I do want to talk a little bit about other things that you do outside of the clinic because you are incredibly involved in advocacy. So tell us more about what you do and how you kind of fit that in because you're very busy at your practice as well.
Yeah, so I do a bunch of different things for advocacy. I think I probably got involved with this just because I started really early with it in medical school. So during medical school, they have a student representative to the board of directors of the Wisconsin Medical Society. And so from my medical school, I was elected to that position and able to serve on the board of directors for the Medical Society. So I was able to see very early on in my career the importance that doctors and our positions and so forth play in advocacy for ourselves, for our patients, for our communities, how we help shape policies and laws and try to make sure that some bills get passed and some bills don't get passed and all of those types of things. So I was fortunate to have that experience all the way back in medical school. And so then fast forward, I went to residency in a different state. I practiced in another state, and then eventually I came back to Wisconsin. And so when I came back to Wisconsin, I again became involved with the medical society here, and eventually was again elected to the board of directors for my district in the state. And so I served on the board of directors for many years again, and then ran for president and was elected president of the medical society in 2022, because I had just started the practice, and Dobbs was 2022. So then it became very apparent very quickly. Wisconsin had an 1849 law in the books when the Dobbs decision came down from the Supreme Court saying that, hey, abortions. And so the 1849 law in Wisconsin basically says that, yeah, any providers providing abortions are subject to felonies and jail and all this kind of stuff. And it became very apparent very quickly that, so I was started my tenure in April of 22, and then Dobbs was in June, July of 22. And so all of a sudden I had to get really comfortable with press releases and interviews and talking points and stuff. And the one thing that occurred to me is that you have to get really good at being able to talk to so many different people with so many different viewpoints. And at one meeting, there was a doctor that stood up and just tried to excoriate the medical society for the fact that we have policy that say that abortion is health care. And so his position, even though he was a physician, was that all abortion is wrong. People should be punished for getting abortions, all this kind of stuff. And at that meeting, which I was the president, so I was running, I was like, oh crap, what am I going to do? And somehow this brilliant idea occurred to me, and I was like, okay, so if it's okay to then say that abortions are wrong, that our legislators can say that abortions are wrong, that's stepping into the healthcare realm, right? So legislators who don't have any medical experience are now making medical decisions. And I knew from experience this provider worked with drug and alcohol abuse. And so I was like, so in the future, when the legislators come in and say, hey, patients who have drug and alcohol abuse problems it's really their own failing. So we don't want to provide any of the medications that can help, and no counseling and no inpatient treatment and stuff like that. So we should just do away with all that because that's really a personal failing by the patients. That's okay then too, right? And so that was like the aha moment, is like, we don't have to agree on all of the policies, but we can agree on is that we don't want legislators telling us how to practice medicine. And so you might not agree with abortion, and that's okay, but you can't have the legislators telling us this. You, as your own provider, your own physician, you can say that, hey, you don't agree with this, and you're not going to provide abortion services. None of this is saying that we're going to force you to say that this is okay or that you have to provide abortion services. But we just don't want that legislation in our exam rooms. And I think that was the biggest thing, was like learning how to talk about different policies, different bills, etc., so that you can get that buy-in from all the different people. And what's been really interesting is I've been doing a lot of testifying at the state level here in Wisconsin because we don't have a DPC law yet. So I've testified, I think, every year since 2021. We've been trying to get this bill passed that says DPC is not insurance. And what I've learned is that when I talk to the Republicans, I'm all about, so Wisconsin never expanded Medicaid, so we have a huge population that doesn't qualify for Medicaid. So I'm like, hey, Republicans, you all don't want to expand Medicaid. So hey, DPC can help fill that gap because we are accessible, we're affordable, et cetera, et cetera. For the Democrats, I use the opposite tactic in terms of the fact that, hey, yeah, the Republicans are never going to expand Medicaid, so we need to make sure that we're covering all these patients. And hey, look at my clinic, because a lot of people think that DPC is only for the healthy and the wealthy, and actually 40% of patients at my clinic don't have insurance, and 40% are Latino, and 20% are BIPOC, and 15% are LGBTQ plus. So I'm reaching all of these patients that sometimes are underserved and have health disparities and stuff. So you take the arguments to the different groups in different ways to try and advocate for what you need, which is always entertaining.
Yes, and that is really that's
Yeah,
marketing,
exactly.
right? And as a DPC doctor, you learn that or you have to learn it. If you haven't, you really need to because that's how you get people to buy in.
And that's, I mean, part of it is just the marketing for
Yep.
DPC. Part of it is advocacy, learning who are you talking to and then how are you going to address that so that you get their buy-in. And so that works both for advocacy and for marketing.
Yep. So that, I mean, obviously you're testifying, you're going to all these meetings. How do you work that into your clinic? Are you 3 days a week or just, I don't know, how do you do it? That's a
Yeah.
lot.
I've set aside, I've changed a lot over the last few years how I did things, trying to figure out, yeah, when my meetings are. So I sit on a couple of other committees and stuff as well. So I work with the Department of Health Services here in Wisconsin and sit on the Advisory Council for Immunization Practices. And then since residency, I've been involved with Reach Out and Read, early pediatric literacy program that's based in clinics where you give out books, age-appropriate language books to newborns through 5 years and talk to parents about the importance of reading at home. So in Wisconsin, I'm co-chair for that advisory council for our Wisconsin affiliate, and then run the Reach Out and Read program at my clinic, which it's a small clinic, so it's not that hard to run. And then I also sat on our Governor Evers' healthcare workforce task force to try and figure out how we can better improve our healthcare workforce here in Wisconsin. So I've done a bunch of different things. What I'm able to do now, especially with DPC, is it's actually easier than when I was in the system trying to do some of these things, is because I have so much more autonomy over my schedule. So I'm able to go in and block ahead of time. Hey, I need to be out for the Council on Legislation from 1 to 4 next Friday. And I have more notice usually, so I'm able to block these out months in advance so I don't have to reschedule patients. But that's also the beauty of DPC, is that I know my patients and they know that I'm involved with a lot of stuff outside the clinic. And so they tend to be really good about, hey, if I call them, I will try and work around their schedule to fit them in again if I have to reschedule them because of other activities that I'm doing outside of the clinic. But for the most part, I get enough notice. And then I definitely changed my schedule. So when I was onboarding patients and filling up my panel, initially when you're starting, and that's the kind of hard part too, is like you're like, I need patients. I need to get them in whenever they can because I need to fill up my panel and I need to get more patients. I need to make this successful. And then once it was clear that this was successful and so forth, and then I have a wait list and then I need another doc and all this kind of stuff, I was like, okay, there's only so many patients I can onboard myself, and there's only so big I want my panel. So once I always feel like it's that initial onboarding the patient that takes the most time and energy to figure out who they are, what they need, follow up, all of that kind of stuff. And then usually once you have them tucked in over the first 3 months or so, it feels like it's much easier once you kind of know them. So now at this point, because I'm 4 years in, 4.5 years in, and I know my panel, it's much easier to take care of them. So I now tend to do Monday, Wednesday, Fridays for seeing patients in clinic. Tuesdays and Thursdays are a lot of meetings and other things from outside the clinic. And usually that works out pretty well. But sometimes things have to be changed around and stuff as well. So
Speaking of how to get patients, how did you get your patient panel? Because you have such a wide variety of
I
patients that
know
you
it's
see.
really weird because I have it's wonderful,
It's
and it's
wonderful.
what's interesting to me is it's the most diverse patient panel I have ever had, and I've worked in an FQHC, an academic center, rural area, all these other areas, and this is the most diverse patient panel I've ever had because I have literally CEOs of companies who are thinking of me as their concierge doc. I have some very wealthy patients who have donated money to the clinic for some of our underserved populations to make sure that they get care and stuff. But then, yeah, I have a huge underserved patient population, BIPOC, LGBTQ plus, patients without insurance, undocumented, all kinds of different things. And what I think started it, some of it I think was because of the networking that I had already had in place a little bit because of all of these other things that I do outside the clinic. So as I talk to my colleagues at the medical society, hey, I'm starting this thing, and hey, I'm doing this or whatever, I have actually, interestingly, a large doctor population of patients at my clinic. And some of that was because they don't want their records in Epic at the local systems because then anybody that they work with can see them and so forth. So what's interesting is you have these people who are like, what EMR system do you use? Is it linked to Epic? And I'm like, no. And they're like, great. Some of it came from the networking and stuff I had ahead of time. And then a lot of it actually, once I had a few patients, especially from the Latino community, and they understood that they could speak Spanish here and we would take care of them and they didn't need insurance and all of this other stuff, word of mouth was huge. And there's one of my first patients in particular was actually a grandma from Bolivia. She was visiting here for 6 months and she got here and has diabetes and she has insulin, and her family made the mistake of putting her insulin in the freezer. So what do you do if you're from Bolivia and you don't have insurance here and you're diabetic and you need insulin? Well, normally you're stuck going to the urgent care as the best option, and then you got to go, and so you have all of the expense of the urgent care and then all of the expense of a pharmacy and the prescription for the insulin and stuff. And the grandma's granddaughter actually knew my, at that time, part-time interpreter. And so she asked, hey, would my grandma be able to come and stuff? And the granddaughter is actually a CPA. She's Latina and has her own business and all that kind of stuff. And so she saw how we treated the grandmother and the time that we took and the money that we saved her and stuff. And she's like, I have insurance, but could I be a patient? And we're like, yep. And so then she signed up, and then all of her kids signed up, and then her sister signed up, and then her family signed up. And then as a CPA, she talks to all of these Latino businesses, and she's like, oh, you guys don't have health insurance, or you need some health care or whatever. So she's always giving out our name. And that has been huge for growth. Sometimes it's that one little patient that leads to, yeah, explosive growth.
So word of mouth and then finding a good referral source. So a CPA
Yeah.
is really a good
Yep.
referral source. I hadn't really
Yep.
thought about that, but yeah,
Other thing I
no,
really did
definitely.
was a bunch of Chamber of Commerce. And when I say a bunch, I mean we have our local one, Fitchburg and Madison, but hitting the smaller ones, so the Latino Chamber of Commerce, the Black Chamber of Commerce, the LGBTQ plus Chamber of Commerce, Out Chamber of Commerce, those were the ones that I think really were important, because then once you're able to talk to other small businesses, and especially these small businesses that don't otherwise sometimes offer insurance, and they're like, wait, I can sign up my employee for this much a month and I can actually either pay for all that myself or have my employee pay half and I pay half or whatever. So now I have a bunch of Latino restaurants and daycares and construction roofing groups and stuff like that who have signed up their employees. A lot of times, yeah, being able to go to those Chamber of Commerce, and especially the specialty ones where you're able to say, yeah, all of my staff speak Spanish and so forth, it can be super helpful.
Yep. Did you have a special kind of elevator pitch for those businesses in particular? Besides the, yes, we speak Spanish?
Yeah, I think the biggest thing for especially small businesses is that they can set it up the way that they want. So we have some of the small businesses so all of the small businesses will pay us directly for the monthly membership fee. But some of them will deduct like half of that monthly membership fee from their employee's paycheck. And some of them will not deduct anything and they pay the full amount. We have one business that actually pays for everything done at the clinic for their employees. So the labs, the meds, the membership fee, which is really quite nice. But the biggest thing was, we're happy to work with you in terms of how do you want to set this up? Do you want to pay for your employees' monthly membership fee? Do you want to pay for part of it? Do you want to pay for any of the labs and meds, etc.? And then making sure that we can send them an invoice every month so they can look at it and see who's on there. And then they have to let us know as people come and go. And we make that pretty easy for them.
Yeah, that's great. We don't have a lot. I mean, honestly, now we don't have any employers, and we just really hadn't pursued that too much. So that's very helpful. How to approach
And
it.
I'm really surprised that, like the ones that you
I,
don't think of, but definitely, like I said, in Wisconsin, fall into those cracks. A lot of these service industries, daycares, because they don't get paid a lot, and yeah, a lot of times they're just small daycares, so they're not offering health benefits or anything. So the other thing that employers like is that this is like a recruitment and retention tool, is that they're able to say, hey, we're covering your primary care needs, so you do have some kind of health coverage. So that can be a recruitment and retention
right.
option for them to use for their employees.
Backing up to something you said earlier about when you were starting your practice and you were telling your colleagues at the medical society that you were starting a DPC. What was the reception like? I'm just curious. What did
That I
other
was
doctors
insane.
think?
You're doing what?
Really, everyone, or was anyone
No,
like
I mean
intrigued?
there was both, right? They're like, you're doing what? And to this day, I when I'm at other meetings and stuff like that, I still get that they don't truly understand what I'm doing sometimes. So like I've brought people out here because I'm also on a primary care investment committee for Wisconsin, and so the head of that is the chair for the Department of Family Medicine at the residency program. And he's just like, this doesn't make sense. And so I had to actually like bring him out to the clinic and sit him down and show him how this works and stuff because he's like, it just doesn't make sense. You can't just charge a monthly fee and that covers everybody. That's capitated care. And I'm like, well, kinda, but it's different. And
Mm-hmm.
so I think there's still a lot of people out there who are like, this doesn't make any sense. But yeah, the more that I've been able to, and the more that people see me succeeding at this and being able to serve very different populations and grow my staff, and now I need a new building because we're outgrowing this one and all of that kind of stuff. Yeah.
It's amazing. It's just you're so inspiring. For real. Just very inspiring. And I really feel like you probably have some Harry Potter magic
No,
where you're cloned and
it's
you are
like that little like thing that
cloned
Hermione
apart.
wears that where she can back time or
Right.
something. Yeah.
Yes.
I
Yeah,
would love
exactly.
that. That would be amazing.
That one. Yes. Well, yes, truly inspiring. And so, if somebody who is either in DPC already or if they're thinking about getting out of fee for service into DPC and wants to do advocacy, what advice would you give
Yeah,
them?
do it. I would say it's simple, just do
Okay.
it. Get involved, especially locally, is sometimes the easiest kind of inroads. So look for like your county medical society or your state medical society, or if you want to go big and so forth, look at the AFP, the AMA, any of these places. The biggest thing I also tell people is that a lot of times you hear disparaging remarks about the medical society, the AMA, the AFP. Oh, I don't like this policy, blah, blah. And I'm like, yeah, I don't like all of the policies that the AAFP supports or the AMA supports and stuff either, especially the DPC doc. I could care less about non-competes or whatever it is at this point in time. However, having that platform to be able to then help to form policy and to have that input is huge. So being a part of these organizations can have a lot of benefits and can get you that platform. Like I said, in my state, we still haven't gotten it passed, unfortunately, but I now know so many of the players, and I've had many of the legislators come out to my clinic so I can show them, hey, this is what DPC is. And now I have the legislators calling me up for other things and stuff too, because they know me now as well. And they're like, hey, there's this bill that has to do with this related to health. Can you tell me what your thoughts are on it? And so, again, being able to then have the ear of these legislators and talk about things that aren't necessarily just DPC or whatever, but can be related to health. The one yesterday that I got called for an interview was related to SNAP benefits, so food stamps and stuff, because of the government shutdown at the federal level. What, as a physician, what do I feel about this? Because we had, again, our medical society signed on to a letter to help our legislators understand that they need to expand funding here in Wisconsin so that people can continue to access food stamps and SNAP benefits while the federal government is shut down. And so, as that physician leader and liaison, now I can go in and say, you know what, yeah, food is important, people. If you don't have healthy food and access to food, you're going to end up with more problems with your chronic diseases, acute diseases. You're going to end up with more ER hospitalizations, more mental health issues, all of these types of things. And so, food is important so that the healthcare system doesn't become overburdened and healthcare costs don't rise and all of that kind of stuff. So,
That's amazing. Yes, great advice. And I want to be mindful of your time. So please tell us if anyone wants to get in touch with you or find out more about your practice, where
absolutely.
should they
So,
go?
website family DPC as in directprimarycare.com. My personal email, pretty easy, Dr. Molaska, which is DRMOLSKA at familydpc.com. And then I'm on LinkedIn. We have a Facebook page. One of my staff finally made me get on Insta. So there's a couple of different options there. But feel free to reach out. Feel free to shoot me an email. There's a form on the website as well if you go there that will get in touch with us.
Wonderful. Well, thank you so much for your time. I'm so glad to chat with you and hear more about what you're doing outside of your practice, which is fascinating. And I hope other people will get involved after they hear what you're talking about. So thank you so much. And we have to do this again. And hopefully I'll see you
That would
at
be
Summit
amazing.
next year.
Thank you for listening to this episode with Dr. Molaska, the 2025 DPC Physician of the Year. And next week, we will hear from the 2026 DPC Physician of the Year, Dr. Michelle Cook. Before you go, I wanted to let you know about the Launch with Guidance, Systems, and Strategies plan. This plan includes 12 weeks of asynchronous coaching with me. You email one question, I send a video response back once a week, and you are backed by the systems and automations within the Harmony Ops CRM for DPC. That means you get automated email sequences, a website chat widget, and voice AI to answer those questions like, do you take my insurance? 24/7. You also have automatic social media posting available, website pages, forms, and surveys. And to make this easier for new doctors just getting started out, it's going to still be at the early practice plan price of $99 per 28 days for the first 3 billing cycles, and then it goes to the regular price of $349. And we look at your data every 2 weeks to see how your social media reach is growing, how your responses are doing, and if your messaging needs to be adjusted to help increase your new patient conversions. It's priced intentionally so that early DPC docs and new DPC docs can take advantage. So I can only enroll 5 people a month for this program. So if you're interested in getting coaching, a little hand-holding as you launch your DPC, take a look, and I would love to see you. That's it for now, and I'll see you on the next episode of DPC Live.
Thank you for listening to DPC Life. If today's conversation inspired you, hit follow, leave a review, and share it with a friend who's ready for change. Remember, wherever you are in the journey, your DPC family has your back. Until next time, keep building a practice and a life that truly fits you.